I am a consultant psychiatrist, and I've been so for 26 years, working in learning disabilities. And I'm seconded from South London, the Maudsley Trust, into NHS England. And I started the job January last year. I've entitled my talk Culture Change and Working in Partnership. And the importance of both is really that we then improve quality of care and support and safety. And safety also means, obviously, reduction in harm. So you will all have heard of Winterbourne View and the scandal and the abuse that residents suffered, which was exposed by the Panorama programme in 2011. And since then, we've had lots of other examples of abuse and scandal, and a lot of professional bodies and organisations coming together and thinking, how can we really work together to stop this practice? This was 2011, and they all signed the Winterbourne View Concordat, but not a lot changed. And so this National Learning Disabilities Programme was set up in 2016, and it was really set up to deliver the Winterbourne View Concordat, but also to address health inequalities, and they're two really enormous things. It's a 3-year funded programme with an awful lot of scrutiny, as you can imagine. It's high profile, it's got ministerial assurance, and Jane Cummings is currently, who's chief nurse in NHS England and at Department of Health and Social Care, is the executive sponsor for the programme. And late last year, Ray James came. I don't know if some of you may know him. He was past president of ADAS, and he came to be SRO for the programme. And so he brings with himself, obviously, a wealth of experience and expertise and networking with local authority, housing and social care in particular. And then, as I said, I was appointed as the clinical director last year. And what we're trying to do is to reduce the reliance on inpatient services for people with a learning disability and people with autism. Because what we're finding is that once people are admitted into hospital, they tend to stay in hospital for an awfully long time, sometimes decades. And they stay in a hospital far away from home, and particularly children are sent far away from home. And the quality of care isn't particularly inspiring, and the environment may actually be adding to someone's presentation or someone's challenging behaviour, as we call it. So the programme is relying on 48 transforming care partnerships that were set up across the country. It's a cross-system thing, so it's not just health, it's also relying on local government, on Health Education England to deliver workforce stuff, and on regulators. And it covers children and adults. And in order to work, it needs the engagement of clinicians and practitioners, as well as people themselves with lived experience. So whilst we're talking about transforming care, which is what this is about, we're also talking about health inequalities for people with a learning disability. And again, we have had loads of national reports and scandals about why is it that someone with a learning disability dies almost 20 years earlier than someone without. And the most recent Learning from Deaths report has found that women with a learning disability die almost 30 years earlier than a woman without. So why is it that a woman can live until an average age of 80, and yet a woman with a learning disability lives an average of 50? And what we also know from these inquiries is that 42% of these deaths are premature and avoidable. And they're avoidable through either public health initiatives, like vaccinations or something, but it's also avoidable with good quality care. So that's a big thing that we're trying to address. So transforming care, the scrutiny was very much about numbers of beds, about how many people have we discharged from a hospital bed, how many people are being admitted into a hospital bed, that sort of scrutiny. And sometimes when you have that sort of scrutiny on the national programme and regional level and at TCP level and at local CCG and borough level and at team level, we miss the fact that actually we're talking about people. We're talking about people and transforming their lives. And since the start of the programme, we have discharged several hundred people who have been in hospital 5 years or more. We have transformed their lives as they've moved from hospital into the community. So even though we put pressure on the system to move as quickly as we can, what we are doing is trying to improve the quality of life of the person and their families. We're looking at it from an individualized, personalized perspective so that they get the care in the right place at the right time. And we want community services to be managing the whole pathway, so that if you have a community team and you have somebody on your caseload who needs to go into hospital for very legitimate reasons, you should be supporting them into the hospital as local as possible and supporting them out again as quickly as possible when they're well. What we don't want is services that see someone needs a hospital admission, admits them into a hospital and think, thank goodness now we can look at someone else on our caseload and because this person is cared for in hospital. So we want a much better management of the whole process and the whole pathway from the community. And the community teams are the ones who will be able to advocate and challenge the services and the support that's given and the treatment that's given in hospital. We want to look very much at quality during admission. So length of stay, we need to know about length of stay. Why is it that people are staying so long? When we review them, why has nothing changed in 6 months' time? That sort of questioning. Serious incidents, lots of serious incidents that you will know of in a hospital setting. The use of restrictive practices, which is in the news today. The use of medication, and lots of other issues. System-wide responses, I've said, to health inequalities, but also really developing and valuing our staff. Because actually, if we don't do that, we don't get staff to deliver the right care, to have the right value set and mindset when you're dealing with vulnerable people. And to address the power imbalance in the system, because all too often we've heard that actually we don't listen, we don't actively listen to people with a learning disability or people with autism, and we don't listen to their families. We don't allow families to visit. We don't. The whole thing about shifting the power so that we actively listen and follow through on what we are hearing. And that takes us really to changing the way we do things, changing the culture within our services. What is culture? It's our attitudes, our values, our behaviours. Individually, and how the system works. It's how we do things. And I know now from my role that there are places in the country where we have 5 times the numbers of admission into hospital compared to other places. And that's because that's the way the system has always responded. So the same presentation in one part of the country will lead to a service that is wrapped around the person in the community. The same presentation in another part of the country results in almost automatic admission into hospital. So why is it so different? So we need to change and challenge the way the system works. So what are your systems like? How does your service or your system respond? How important is quality and quality improvement and the patient experience or the experience of the service user? How important is that in your decision making? And some of the conversations we've had with families in particular recently is very much human rights. These are our human rights. They're not privileges, they are rights. So If I ask you, do you work in a learning organisation? Where Lynn was saying, well, if you've got a serious case review, are we learning the lessons from this? Are we putting these things into practice? Are we constantly monitoring and reviewing? Is your organisation a learning organisation? And do you feel valued in your organisation? And how does your organisation treat someone with a learning disability? Does your organisation employ someone with a learning disability? Do you have an executive member of your board or the most senior committee accountable for the experiences of people with a learning disability? Do you have quality reports specifically on learning disabilities? And it's very, very variable across the country. Certainly when I visit hospitals and trusts, it's incredibly variable. What we've done nationally to try and support the culture change, and I'm just going to sort of share a few examples with you, is that everything that we do, we co-produce. And when we use the term co-production, we don't mean collaboration. We mean co-production working with experts by experience and their families. And we also employ 5 learning disability advisors on our programme, all band 6 full-time employment. And then we have a advisory group of parents and others. We produce co-production tools, which are used with TCPs and local partners. We have families and clinicians working together to co-produce training. We have a positive language project, because language is so important. How we use words to describe people really does change the way we think about them. And I think coming into this post and working with our learning disability advisors professionally as partners is very different from working in a clinical way with them as my patient. It's very challenging, but it's completely different, and you get a completely different perspective of how you work with someone. We're also working with the media, creative work. So Mixer is a theatrical company made up of people with and without a learning disability, and they help us spread the message, and they write their own plays and their own sort of musical numbers and things, and they go around the country speaking and singing and acting various things. And we have a number of other art commissions as well. We have the Ask, Listen, Do project, which is a complaints management project, which will be launched at the end of this month, I think, officially launched. And we've worked very hard with MenCap, with the Don't Miss Out campaign. Has anyone heard of the Don't Miss Out campaign? Yeah, hope so, anyway. And the Don't Miss Out campaign is very much about ensuring that people with a learning disability is known, that they are known to their general practice, and that they are offered to have their names on the GP learning disability register. Because once you're on the register, the GP can then offer you annual health checks. They can start making the reasonable adjustments and flagging it on the system, which will then be shared with other systems. The other thing that we're doing, or one of the things we're doing, is stopping over medication, which is another sort of culture change. So if I say to you that in the normal community known to the general practice or known to general practitioners, what percentage do you think will be on major tranquilizers, antipsychotropic medications? How many do you think, percentage-wise, without looking at the handouts? Give me a number, percentage. Sorry? 10, 6, 8. Okay. If I say to you that the prevalence of schizophrenia is 1% in the population, so in general, in the community, 1% of the community will be on major tranquilizers, psychotropic medication. But for the learning disability population who are known to their GPs in the community, it's 17%. So almost 1 in 5 are on medications. Why is that? Prevalence of schizophrenia is 3 times So maybe you'd expect 3%, but why? Why 17%? And we know that a lot of the medications are used where there is no clinical reason put in the notes. So are they used in a way to dampen down behaviours that people find challenging? So that's our major challenge, is that culturally we need to think of other ways and put other packages of support in place so that we don't over-medicate people. Because, you know, the medications are, not only are they strong, but they also have huge side effects and reduce not only quality of life, but life expectancy. So we have the STOMP project, which is Stop Over-Medicating People with a Learning Disability, been signed up with by the Royal Colleges and Societies, by voluntary organisations and social care, and now this year by providers. We're working hard with family carers to increase awareness, education. We have pilot models around the country about how this might work. We've got new training packages, quality improvement projects, and new research, actually, because it's not just this country. In fact, it's other countries in the world that have very similar practice. So that's one thing that we're doing to try and change culture, is that when someone presents with a behaviour that challenges, you know, we think about, obviously, the physical health, reasons why they might be behaving this way. We think about the communicative reasons why they may be behaving this way, the environment and why they may be behaving this way. But we also think about what can we do, what positive behavioural supports should be in place that will allow them not to use these sorts of behaviours as a means of communication. The other thing that we're doing is that we're trying to prevent admissions where possible. So we have introduced, a couple of years ago now, care and treatment reviews, and I'm sure many of you have been involved in them. We have them pre-admission, and we have them when someone is admitted into hospital. This is a mental health hospital, not for physical health care. And this involves commissioners, it involves independent expert by experience, and it involves an independent clinician as well as the local team. And what we're trying to do is to say, well, are there other alternatives to hospital admission? Because we know once you go into hospital, you'll be there a long time. And when we have done these care and treatment reviews, what we've found is that over 75% result in a decision not to admit into hospital. And it's not that we delay the admission, is that they don't go into hospital. And the same for children, actually. So children will be care, education and treatment reviews. And again, we found about 75-80% result in a decision not to admit. But it's just using resources creatively to support the person in the community. The other culture change that we are trying to influence, obviously, is learning from deaths, learning from these premature deaths. So we're making learning happen in every place. So every borough has now a leader steering group. We have a learning interaction group now that's looking at early findings and putting change into place. So we've got the National Sepsis Programme because we heard sepsis was a big killer. We've got the flu vaccination programme that started this year into schools. And we've got lots of other things. But one of the key things is that these reviews into deaths are not reviews about the last episode of care, because that's what happens in hospitals. It's about the whole pathway. It's about what could the system have done earlier, maybe to have prevented this, to have made a difference to this person's life. Oops. And so this is just to remind me and everybody else, I think, was that it's in the NHS planning guidance, both the transforming care targets, the health inequalities, the GP registers and annual health checks, and the health inequalities stuff. But you will know that in June this year, the Prime Minister also announced a funding settlement for the NHS. And so we were tasked with, in August, in August, it was also announced that learning disabilities and autism would be part of this, which was a fantastic opportunity. And it becomes now one of the 4 clinical priorities in the plan. So announced in August, we had 6 weeks to think about how we might develop this and what we would do. So the 10-year plan looks at 4 main priorities. It looks at cancer services, services for heart and lung, mental health services, and then learning disabilities and autism, as well as lots of other things that will be enablers or things that go across, like health inequalities or prevention, data, that sort of thing, GP practices. So there are lots of work streams. And 3 of us have been tasked with leading the negotiations about what we would try and deliver and how much we would ask for in terms of the NHS plan. There's been a lot of, not talk, but a lot of thought about, well, actually, this is an NHS plan, and I know that there's huge amounts about local authority that also need to be addressed, but this is not a government plan. So we were tasked with saying, what can the NHS do that might improve the lives of people with a learning disability and people with autism? And the main aim is reducing health inequalities. So there are lots of things that we can draw upon at the moment. So we're drawing upon the autism strategy already in place, the lessons from transforming care, as I said, the learning from death stuff, the annual health checks, knowing that we are developing this within an integrated care system delivery. So, you know, that's what we're thinking. 10 years' time, this is where we're going to be at. And of course, we have the consultation for mandatory training that was announced in the middle of September. So we've been working really hard, as I said, in the last few weeks to engage, particularly with experts by experience and families. We've had lots of events around the country. We've had events led by Learning Disability England. We've had events led by the Autistic Society, National Autistic Society, and we have specific focus groups for people who are in secure settings, people with complex needs, non-verbal, children, that sort of thing. So we're trying to reach out as much as we can, as well as obviously networks and professional bodies and things. And we've been speaking very much about the sort of themes we wanted to put into the plan. Better Start is a really big theme because we know that there are so many children who need additional support to prevent them going into hospital, but also much earlier diagnosis, particularly for autism, much earlier diagnosis, pre-diagnostic supports, diagnosis and post-diagnostic supports. The whole thing about wrapping around care, the whole thing about getting local authority, education, health together in terms of how we work. Better Health, which is much more about population health, about preventative aspects and what we might do, about health promotion, about the environment, that sort of thing. Knowing how the population health is and using that data to plan and deliver care. Better Care, that's about quality of care and harm reduction, making sure that actually people can access services and that they have the same access and the same outcomes as other people. But also just picking up on what Lynn was talking about earlier, trauma-informed approaches, because we're now knowing that there's a lot of things that we do that actually perpetuate someone's experience of being traumatized. And so that sort of thinking needs to permeate almost everything that we're doing. Better Lives, which is very much about people being in their own communities, living the life they want to live, having friendships, having the support, having employment, those sorts of things that are fundamental. But obviously that's very much about working with other partners. And last but not least, the real message that all means all, that actually people with a learning disability and autistic people have the same rights as everybody else to live their lives, to access support, to have reasonable adjustments in place so that they don't miss out. So that's the biggest theme. This is just to say that we've done all the engagement work. And I don't know if you can read that, it's very small, but this was a poem that a mother wrote when she heard that we were working on the 10-year plan. Now, of course, this is a 10-year plan, so thinking about what the NHS is going to be like, or what the world is going to be like, and our environment in 10 years' time is hugely challenging, as you said before, Lynn. So it's, we're not talking about what's happening now and just improving it. We're talking about in 10 years' time. So one of the things we're thinking is, well, 10 years ago was the first iPhone was launched. And the world has changed since then. There's going to be massive change in the next 3 to 5 years in terms of IT and digital technology and things like this. And we can't afford to have digital innovations being created that inadvertently increase the health inequalities and the health gaps. So we need to also think about those things. So we've now written our draft plan, and it has been submitted. And we wait for the next stage, because everything needs to be finalised before the budget, which has been brought forward to the 29th of October. So we'll wait and see. But actually, we have very ambitious plans to really change the way the NHS works. And key to that is the NHS, the whole of the NHS, not just learning disability services, the whole of the NHS actually really listening to and valuing people with a learning disability and autism. So I'm going to end there and take questions. Thank you.